Thank you, Dr. Stodinger, for that wonderful introduction. So like he said, I'm going to talk about cadaveric exploration of the relationship between the posterior portal of the shoulders and the axillary nerve relationship. So here's my team, Cameron, Chloe, Swathi, Nicholas, Delaney, Dr. Steele, and Dr. Zolniras. Okay, first let's go over the introduction. So I'm going to touch up on some brief anatomy before I talk about the variants here, but first thing we need to know is the bony landmarks here. So this is this posterior aspect of the shoulder. We're looking right currently at the scapula. This is the scapular spine, and it turns anteriorly to become the acromion, and that is that lateral edge of the shoulder. And then you can see that this is the capsule, and then this is the humeral head, or at least the greater tuberosity there, and lesser's on the anterior side. So this now is the quadrangular space. Teres minor comes up on the superior aspect of the quadrangular space. Long head of the triceps becomes the medial aspect. The humerus becomes the lateral aspect, and teres major becomes the inferior aspect. And so the axillary nerve originates from C5 and 6 and works its way down and all the variations occur from the quadrangular space on and how it innervates the muscular belly. So there's 3 bellies to this deltoid here. So the deltoid normally attaches the posterior aspect of the scapular spine, the acromion, and some part of the clavicle. And so we have peeled it off so that you can see the quadrangular space and the branching points. So there are 4 very classic type variations, A, B, C, and D. And so A is the most common and D is the next most common. A, as you can see, the anterior branch supplies the anterior middle and posterior bellies of the deltoid, while the posterior branch supplies that posterior belly and then becomes cutaneous, the lateral cutaneous sensation of the shoulder there. And then there's a branch that comes off and supplies teres minor. So the axillary nerve supplies 2 muscles, deltoid and teres minor for summary. And then we see this at 84% of the time. And we see this at roughly 9% of the time. And so this is the next most common, where you can see the anterior branch supplies the anterior and middle belly, and the posterior branch supplies the posterior belly and becomes cutaneous. So this is what is known currently in literature. And so we'll see exactly where that takes us later. Okay? So, why are we worried about this? What's the big deal, right? And so we're worried about the closeness of that. The muscle belly obviously is protecting this nerve, but it is very close in terms of the relationship between that belly and the skin itself. And so its close association with the posterior lateral aspect of the shoulder puts it at risk of injury when we place a portal or a trocar or scope or any sort of instrument that has to access this cavity, right? And so if you're not really familiar with arthroscopic procedures, it is used to repair the labrum, repair rotator cuff muscles, decompress certain bony marks like clavicular decompression is very common for any kind of impingement process. And so to access the shoulder joint, you have to do an outside in technique, which is a cut mark on the outside surface of skin, and then they pop down to the capsule itself and insert the scope. And from there, they can go from an outside in technique, which is what I just described, to an inside out technique where they can use the camera to see and then also access the joint from the outside. Okay. And so the most common injury is actually from an anterior glenohumeral dislocation, about 48% of the time. So the other 52% of the time, it's coming from either blunt force trauma, fractures, penetrating traumas, or iatrogenic. Okay. And so iatrogenic is what we're really focused on here, and that often comes from arthroscopic shoulders, okay? And so the majority of these injuries are going to be temporary neuralgia, which will resolve in its own time frame, 6 to 12 months for the most part. Now, and this isn't always true with older individuals. Young patients, they're going to have a better likelihood of recovering from an injury like that. But if they have complete transection, which can happen, then it's basically permanent in all ages. Let's see. So the epidemiology of this happens with a female predilection of about 1 to 3 per 100,000 a year. Okay, and the axillary nerve accounts for 6 to 10% of all complications during a shoulder surgery, such as this one, or like an open or total. But this accounts for all types of shoulder surgeries in this number here. Okay. And so injury presentation after you were to injure something like that can present as a rapid loss of shoulder contour, which really is referring to this gentleman's shoulder here. You see how this side, his right, looks very normal in contour. It's rolling hill and then coming down into the arm. Right, this is a rolling hill, and then now you see all this bony and bumpy looking features here, and that is the clavicle becoming prominent, and then the acromion right here becoming prominent, and then you can see part of the scapular edge there, or the scapular spine there, working this way, and then you can really see the emphasis of that humeral head, and you can almost see what looks like a greater tuberosity and a lesser tuberosity right here, right? And then you can kind of see that contour of the head coming down into the actual diaphysis. So that's a complete loss of all your deltoid atrophy, or a complete loss of shoulder contour, and then becoming because of deltoid atrophy. And so with certain injuries, you can have a gradient impairment of abduction. This gentleman here had an injury when he was 18, and now this is about, I think he's 43 in this case study, and he had regained some function. So he had not an incomplete tear or injury to his nerve, and so he's been able to kind of rehab some of it, at least some of it. But he has no sensation over the lateral shoulder, and so there can be varying degrees in presentation of this depending on where you hit it at, right? So like we were showing earlier, if you were to hit it here and you catch all three branches essentially, the nerve to teres minor, anterior, and posterior, you can have a complete deficit. But if you catch it out here, you might lose, might have a varying degree of abduction ability because you lose middle and posterior, or you lose, just posterior, and so you start seeing weakness. So you can imagine that it's going to be a very gradient impairment. Okay. So literature review. There's limited studies that really analyze exactly each portal. I went to the American Academy of Orthopedic Surgeons and looked at what they had, and then I used their reference points, and then I found more of my own. But most people refer to this portal here, which is our one, that is our posterior portal, as very safe. It's often used first to establish access to the joint space. And then 7 has been described as less safe, used with caution. I think they reference it at 2.9 centimeters away in previous literature. And this one to be, I think 4 or 5 centimeters away. And then this one was less studied. And then this one was starting to get traction in terms of it being studied. And they were saying, I don't know if this is the one, I don't know if this is as safe as we think it is what the literature is starting to say. They used to say that this is incredibly safe and that this is far inferior to the nerve and greater than 5 centimeters off the lateral edge of the acromion, and so on and so forth, and really describes it as safe. And now at least one project has come out, maybe 2, as far as I found, that were saying, I don't know if that's true. And so that's what sparked this idea, is that we probably need to review a lot of these. And so I picked these 4 because the course of the axillary nerve, it makes most sense just to stick to these 4. Okay, so methods. I was able to harvest 47 shoulders of the 26 formalin involved cadavers here on the Joplin campus. The axillary nerve variation was classified and set forth by Lee. I'm sorry, I can't pronounce her name. If she ever finds out that I can't, I'm sorry in advance, please forgive me, but we're going to refer to her as Lee. Okay. All measurements are measured by ImageJ software. So prior to the dissection, to simulate the arthroscopic entry, right, we used a needle, used a long needle. It doesn't have the same diameter as a scope. I'm fully aware of that. Scope is 20 millimeters in diameter. And so we are kind of giving that surgical safety around the center point of our needle. And so we used the needle and we followed the American Academy of Orthopedic Surgeons. I guess their stepping points and how they found these. So for example, They use the acromion here on the lateral surface of the arm. They mark that out, and they use the scapular spine. They mark that out, and they call this, starting point for some of these. So you come in 2 centimeters and then down 2 to 3, and you try and find that soft spot between the humeral head and the glenoid. And then that's where you start to aim towards the acromion, which is over here, or sorry, the coracoid. So coracoid process over here at C. So you would aim towards that direction, and I did recreated all those things, and I felt the 2 pop. So the pop through the skin, and then the pop through the actual glenohumeral ligaments. So and I knew I was in the cavity at that point, and so then that's when I would measure. And so I did the same thing. I would follow the exact same procedure that they do in the OR, and I would take measurements down to each of these 4 portals. Okay, and so I did that before the students had a chance to remove the skin, and then I had them remove the skin and dissect for me. And then we used those same landmarks to actually measure from that same landmark down to the nearest nerve. And so if you can follow here, let's start at B actually. B is going to be easier for you to understand. So B, you come from the acromion and you find that corner where the scapular spine and the acromion meet, and you work your way down from that. And so that'll find your way into A, or 8, I mean. So B and 8 are overlapping. So portal 8 here, and this was the corner that we're calling B. So we're calling this plane B and landmark B. Okay, they're kind of one and the same. And so 8 travels through that, and then it's about 2 centimeters this way and 2 centimeters this way to get to either C, which becomes 4, and A, which becomes 1 and 7. So we see that again here. So we find that corner, we move 2 centimeters this way, and then we move down to measure our distance. So A landmark and A plane, 1 and 7 portals are in there. And then C, moving from B, 2 centimeters anteriorly, we have plane C and landmark C, where portal 4 is found. Okay, and so we did those measurements and then we overlaid those measurements related to the skin measurements. Okay, and so again, just to show you that 1 and 7, A, 1 and 7, and then 8, and B, and C with 4, okay? And so results and discussion. So our population data, we had 26 cadavers, we had 14 females, 12 males, 47 shoulders. We lost 5. There was a couple fractures or inadequate dissection that led to some damages to the nerves, or just I think there was a couple fractures and some hardware in one of them, but either way. The average age was about 76.5. The height was 5'6.5", and 47 pounds. And so I was very curious about the BMI, the average BMI, and I looked it up, roughly 22, 23. So a very healthy BMI, or a muscular skeletal healthy anatomy, right? And so that would be about the perfect patient you would want to represent your population. Okay. And then the arm length was 74 centimeters. All right, so this is Lee's variation data here. She found that 84% of the time they had A or type A variation or class A variation, and she had class D variation coming in second place. And we had about the same. So we were off by 5% with class A, and we were 2% off with class D. So we were very, very similar in our study's population compared to I guess her population size in the United States. So here's some descriptive stats of our measurements here. So if we look at A, you can see that this is that measurement from the bony landmark down to the nerve. And so that came in at 5.6, and then 1 came in at 3. And 1 refers to that posterior portal, the safest one, the one we were calling safe from the beginning. We are finding out, 2.5, we'll call it, centimeters away is pretty safe. And then we look at 7, which is the one they were already calling not so safe, use with caution. We found it to be slightly different than what they were saying. They were saying 2.9 centimeters. We are saying 0.25 centimeters here in your mean difference. And then 8, which didn't have as much literature on it, we found or determined to be pretty far separation between these two, right? So 2.8 versus 5.5 in terms of that distance. And then it starts to climb back up. So you can see it kind of dips down naturally and then climbs back up around that head and around the capsule. And we can see that it is coming back together. And so C, which is used quite often, is actually 0.07 centimeters away from each other with a 4.7 and a 4 versus a 4.8. Okay. And you can see the standard deviations are all relatively similar. Okay, and I did a kernel density estimation with our controls here, where you can really see and assess the differences here. So you can see that A, which is our distance again from bony landmark down to the nerve, sits in this density values between 5 and 6 predominantly, scattering out as low as 4 and high as 7. And then 7, which is that portal that we were saying, I don't know if that's necessarily safe. We are seeing, for at least in terms of this density mapping here, that it is significant in overlap, and that it should be used with caution. While the other one that they use as the primary portal is very limited in its statistical overlap, as you can see here. And so now we're looking at B and 8, which is the axillary pouch portal. You can see that the distance down to the nerve is much farther inferior, often staying between 5 and 6, while the distance down to our portal is much higher than that. And so higher as in relative to the nerve, sitting in about 2 to 3. Okay. And then if we look at this is our last one here. This is portal 4, which is our posterior lateral portal, has statistically significant or statistical density overlap here. And so as you can see, they kind of follow each other in the way they represent in our population. Okay, and so this is basically what I just said now in words. So the posterior, which is 1, and axillary pouch, which is 8 portals, where it had very limited statistical density overlap and should be deemed as safe arthroscopic access. The proximity of posterior inferior portal, which is 7, to the axillary nerve has been studied and used with caution as it is previously described to be 2.9 centimeters away from each other. However, other studies found the difference in means from the axillary distance and the portal distance to be about 0.25 centimeters. And like I said, the diameter of the camera is about 20 millimeters, which would be 0.2, right? And so that's a very, very narrow window. I would recommend using that with caution from here on. Axillary nerve and the axillary pouch portal relationship had a mean difference of 2.7. That's a very, very safe distance. The axillary nerve in the plane C was previously described as far inferior to the placement of the posterior lateral portal 4 and a greater than 5 centimeters from the acromial edge. This study found that the nerve and the posterior lateral portal have a considerable overlap with a mean difference of about 0.07 centimeters, which is obviously very scary close, right? And so conclusions, our posterior inferior portal should be used as a last resort and with extreme caution, as the portal has a high likelihood of intersecting and damaging the axillary nerve. And so if we look back at our quadrangular space, posterior inferior portal is actually kind of hovering in that area. So this is, if you're going to damage something when you're inserting a posterior and inferior portal, you're going to have a significant amount of damage. We're talking about, it's gradient abduction impairment. This would be one of those times where it's going to be full effect. You have zero ability to abduct, at least in terms of the deltoid itself. Obviously, supraspinatus is going to be able to pull that first 15 degrees, and then that's when the deltoid really starts to get into its function, right? And so the posterior lateral portal has been previously described as safe. However, the study recommends it using an alternative location while further studies analyze this portal and its relationship with the axillary nerve. So limitations was sample size size, nerve conditions, demographic data. A prone dissection was done. However, during surgery, they're often in an abducted arm position. So that would shorten the nerve, actually bring it up higher. As you abduct the arm out, it actually shortens the distance the nerve has to travel. And so it pulls it up relative to the lateral edge. And so that would make it even more dangerous, in my opinion. But farther studies definitely need to be done. And I think that was one of the limitations, at least that I can imagine, that maybe certain things will present differently. And then also we did an outside in technique for all portals instead of, an inside out is often used after establishing your first portal. So I want to, take the time to thank our donors for their selfless sacrifice, and not only made this research possible, but enhanced the education of all of our students. And thank you to class of 2027. Here are my references. Any questions?